Good morning everyone. In this video we will learn about the mallet finger. Mallet finger is a deformity. Definition of mallet finger. Mallet finger is a deformity caused by rupture or avulsion of the extensor tendon at the distal interphalangeal joint, resulting in inability to actively extend the tip of the finger. A common injury affecting the fingers. Mallet fingers occurs when the extensor tendon responsible for straightening the tip of the finger is damaged or torn. As a result, the distal interphalangeal joint remains bent and the patients cannot actively straighten the fingertip. This injury usually occurs due to sudden force that bend the extended fingertip, commonly during sports activities or accident. Early diagnosis and proper treatment are important to restore normal finger function and prevent permanent deformity. To understand mallet finger better, let us review the anatomy involved in the condition. Structures involved: distal phalanx, the bone at the tip of the finger; distal interphalangeal joint, the last joint of the finger; terminal extensor tendon, extend the fingertip and insert into the distal phalanx; extensor mechanism, a network of tendons that helps straighten the finger. Key anatomical changes in mallet finger. Rupture of the terminal extensor tendon. To understand mallet finger, it is important to know the anatomy involved. The condition affects the terminal extensor tendon, which is attached to the distal phalanx and is responsible for straightening the fingertip. This tendon crosses the distal interphalangeal joint or when the tendon ruptures or pulls off a small fragment of bone from the distal phalanx, the patient loses the ability to actively extend the fingertip. As a result, the distal interphalangeal joint remains bent, producing the characteristic mallet finger deformity. Now that we have understood the anatomy involved, let us discuss the causes and mechanism of injury leading to mallet finger. A sudden force strikes the tip of an extended finger. The fingertip is forcibly bent while the extensor tendon is actively contracting. This causes rupture of the terminal extensor tendon or avulsion fracture of the distal phalanx. Common causes: ball sports, example cricket, basketball, volleyball; finger jam injuries, falls and accident, direct trauma to the fingertip. The mechanism of injury in a mallet finger involves a sudden force applied to the tip of an extended finger. When the fingertip is forcibly bent into flexion, the terminal extensor tendon is overstretched and may tear. In some cases, instead of tearing, the tendon pulls off a small fragment of bone from the distal phalanx, known as an avulsion fracture. This injury commonly occurs during sports when a ball strikes the tip of the finger, but it can also result from fall or direct trauma. After understanding how the injury occurs, let us look at the clinical features and signs seen in the patients with mallet finger. Clinical features of mallet finger. Side pain and tenderness over the distal interphalangeal joint, swelling around the fingertip, inability to actively extend the distal phalanx, fingertips remains in a flexed position, reduced grip function, bruising may be present, difficulty performing fine hand activities. In chronic cases, swan neck deformity may develop. The clinical features of mallet fingers are usually easy to recognize. Patients commonly complain of pain and tenderness over the distal interphalangeal joint. Swelling and bruising may be present around the fingertip. The most characteristic feature is the inability to actively straighten the tip of the finger, causing it to remain in flexed position known as the mallet deformity. Patients may also experience difficulty with gripping and performing fine hand movement. If left untreated, chronic mallet finger can lead to secondary deformities such as swan neck deformity. Next, we look at the Doyle's classification of mallet finger. Type 1, close injury with or without a small avulsion fracture. Type 2, open injury with tendon laceration. Type 3, open injury with loss of skin and tendon substance. Type 4A, transfacial fracture in the children. Is mostly commonly most commonly seen in children's. Then type 4B, hyperflexion injury with 20 to 50% of articular surface involvement. Type 4C, fracture involving more than 50% of the articular surface with volar subluxation of the distal phalanx. Doyle's classification is commonly used to classify the mallet finger injuries based on the type of severity of the lesion. Type 1 refer to a closed injury which may occur with or without a small avulsion fracture. Type 2 is an open injury involving tendon laceration. Type 3 includes open injuries with loss of both skin and tendon tissue. Type 4 represent mallet fractures and is further divided into 3 subtypes. Type 4A occurs in children as a transfacial fracture. Type 4B involves 20 to 50% of the articular surface. And is often associated with all or subluxation of the distal phalanx. This classification helps guide treatment decision and predict outcome. After identifying the clinical features, After identifying the clinical features, the next step is to confirm the diagnosis through physical examination and imaging investigations. First one is clinical examination. History of trauma to the fingertip, finger held in flexion at the DIP joint, inability to actively extend the distal interphalangeal joint, tenderness and swelling over the distal interphalangeal joint. Next, we look at the radiological examination. X-ray taken AP on lateral views, it confirms avulsion fractures, assess joint alignment, rules out other fractures or dislocations. Next, we look at the differential diagnosis. The diagnosis of mallet finger is primarily based on the clinical examination, a history of trauma to the fingertip, along with the inability to actively extend the distal interphalangeal joint, strongly suggests the condition. On examination, the fingertip is typically held in a flexed position, with tenderness and swelling around the distal interphalangeal joint. X-rays are taken in anteroposterior and lateral view. Lateral view. To identify any avulsion fractures, assess joint alignment, and exclude associated fracture or dislocation. Once the diagnosis has been confirmed, the next step is to discuss the treatment options available for managing mallet finger. First one is non-surgical treatment of mallet finger. Splinting. Distal interphalangeal joint maintained in full extension or slight hyperextension. Continuous splinting for 6 to 8 weeks. Common splint, stack splint, aluminum splint, and a custom thermoplastic splint. Pain and swelling management, ice application, elevation, analgesics are prescribed. Then physiotherapy, maintain mobility of unaffected joint, gradual distal interphalangeal joint exercise after splint removal, strengthening and functional training, patient education. Do not remove the splint during the treatment period. Keep the distal interphalangeal joint extended at all times. Follow up regularly. Most causes cases of mallet finger can be treated successfully without surgery. The main treatment is continuous splinting of the distal interphalangeal joint in full extension or slight hyperextension for 6 to 8 weeks. It is very important that the fingertip remains extended throughout this period, as even a brief flexion can disrupt healing. Pain and swelling can be managed with ice application, elevation, and medication. After splint removal, physiotherapy is started to restore range of motion, strengthen hand function. Patient compliance with splinting is essential for achieving good outcomes. While most mallet finger injuries respond well to conservative management, certain cases record surgical intervention. Let us now discuss the indications and method of surgical treatment. Indications for surgery. Large avulsion fractures, all or subluxation of the distal balance, open mallet finger injury, failed conservative treatment, chronic mallet deformity. Then surgical procedures are K-wire fixation, extension block spinning, open reduction and internal fixation, tendon repair or reconstruction. Surgical treatment is considered when conservative management is unlikely to provide satisfactory result. Common indications include large avulsion fractures, volar subluxation of the distal balance, open injuries failed to splint treatment, and chronic deformities. Various surgical techniques are available, including K-wire fixation, extension block pinning, open reduction and internal fixation, and tendon repair. Following surgery, the finger is immobilized for period to allow healing. Physiotherapy is then initiated gradually to restore joint mobility, strength, and hand function. Whether treated conservatively or surgically, physiotherapy plays an important role in restoring finger movement and function. Let us now discuss the physiotherapy management of mallet finger. Immobilization, then gradual physiotherapy, range of motion and strengthening exercises. Next, we look at the complications of mallet finger. Persistent extension lag at the DAP joint. If mallet finger is not treated properly, or if the patient does not follow the treatment protocol, several complications may occur. The most common complications is a persistent extension lag, where the patients cannot fully straighten the fingertip. Some patients may develop a permanent mallet deformity or stiffness of the DAP joint. Chronic pain, swelling, and reduced grip strength can also occur. In long standing cases, a swan neck deformity may develop due to imbalance of the finger extension mechanism. Degenerative changes in the distal interphalangeal joint and skin problems from prolonged splint use or other possible complications. After understanding the possible complications, let us summarize the key points about mallet finger and its management. To summarize, mallet finger is a common injury affecting the extensor mechanism of the fingertip. It usually results from a sudden force that bends the extended finger, causing tendon rupture and avulsion fracture. Patient present with pain, swelling, and an inability to straighten the fingertip. Diagnosis is confirmed through clinical examination and radiographic evaluation. Most cases respond well to splinting, while selected cases require surgical intervention. Early diagnosis, appropriate treatment, and physiotherapy are essential for achieving optimal recovery and preventing long-term deformities. Next, we look at the jersey finger. Jersey finger is a common tendon injury of the hand. Jersey fingers occurs when the flexor digitorum profundus it is forcibly pulled away from the attachment on the distal phalanx. As a result, the patient is unable to actively bend the tip of the affected finger. This injury commonly occurs during sports when a player grabs another person's jersey and the finger is suddenly forced into extension. Early diagnosis and appropriate treatment is important to restore finger function and prevent long term disability. To understand jersey finger better, let us first review the anatomy involved in the injury. It is important to know the anatomy involved. The injury primarily affects the flexor digitorum profundus, which is responsible for bending the fingertip at the distal interphalangeal joint. Uh, the flexor digitorum profundus tendons insert at the base of the distal phalanx. During a forceful extension injury, the tendon may be pulled away from its attachment, resulting in tendon avulsion. The tendon often retracts toward the palm, causing loss of active flexion of the fingertip. The ring finger is most commonly affected because of its anatomical position and tendon characteristics. Now that we have understood the anatomy involved, let us discuss the mechanism of injury and how jersey fingers occurs when a flexed finger is suddenly and forcibly extended. The flexor digitorum profundus tendon is actively contracting during the injury. Sudden extension causes avulsion of the flexor digitorum profundus tendon from its insertion of the distal phalanx. After understanding how the injury occurs, let us discuss the clinical features and signs commonly seen in patients with jersey finger. The clinical features of jersey finger usually appear immediately after the injury. Patients often complain of sudden pain and swelling on the palmar side of the finger. The most common characteristics finding is a inability to actively flex the distal interphalangeal joint because the flexor digitorum profundus tendon has been avulsed. As a result, the fingertip remains relatively extended. When compared to the other fingers, patients may also experience reduced grip strength, tenderness along the tendon path, bruising, and difficulty performing activities that require grasping or holding object. After identifying the clinical features, the next step is confirm the diagnosis through the physical examination and imaging investigations. The diagnosis of jersey finger begins with through the clinical examination. The patient typically gives a history of a forceful extension injury and is unable to actively flex the distal interphalangeal joint. Tenderness is usually present on the palmar side of the finger. X-rays are often to identify and avulsion fractures and to rule out associated bony injuries. Ultrasound can be used to visualize the torn flexor digitorum profundus tendon and determine its Okay, after identify the investigation, next we'll learn about the management of Jersey finger. Uh, the management of Jersey finger depends on the severity and timing of the injury. Unlike mallet finger, most Jersey fingers injuries require surgical treatment because the flexor digitorum profundus tendon retract away from its insertion. Surgical repair involves reattaching the tendon to the distal phalanx using various fixation techniques such as suture, anchors or pull-out sutures. In chronic cases, tendon grafting or reconstruction may be necessary. After surgery, a structured rehabilitation program is essential. This includes splintering, controlled range of motion exercises, gradual strengthening, and functional hand training to restore normal finger function. Following treatment, it is important to understand the possible complications that may occur if the injury is not managed appropriately. Let us now discuss the complications of Jersey finger. If Jersey finger is not diagnosed and treated early, several complications can occur. The most common complication is persistent inability to flex the distal interphalangeal joint. Resulting in reduced grip strength. Finger stiffness and flexion contracture may develop due to prolonged immobilization or inadequate rehabilitation. Surgical complications include tendon re-rupture and scar adhesions, which can restrict smooth tendon movement. Chronic pain, swelling, swelling, and decreased hand function may also occur. Therefore, early diagnosis, timely surgical repair, and proper physiotherapy rehabilitation are essential for achieving the best functional outcome. After discussing the complications, let us summarize the important points regarding Jersey finger, including its anatomy, mechanism of injury, clinical features, diagnosis, and management. To summarize, Jersey finger is a tendon avulsion injury involving the flexor digitorum profundus tendon, most commonly affecting the ring finger. It typically occurs during the sports activities when a flexed finger is suddenly forced into extension. The hallmark clinical sign is the inability to actively flex the distal interphalangeal joint. Diagnosis is confirmed through clinical examination and imaging studies. Most cases require surgical repair followed by a structured rehabilitation program. Early diagnosis and treatment are crucial to restore finger function, maintain grip strength, and prevent long-term complication. Thank you.